for the treatment of COVID have been carved to us, but testing has not been. So OTC tests are not carved to fee-for-service. Okay, so Eric, that brought up a number of other questions we can discuss offline, which of course we're developing this policy and we'll do it. We will communicate with the ACOs as that as we define some of those parameters around tests and cost and impact. Okay.
No, thank you. Appreciate it.
Many of these agents, as you know, when they become available, there isn't published pricing available, and so we've worked with our one of our pricing vendors, Myers and Stauffer, to establish some pricing, collect invoices. A lot of the drugs under the EUA, of course, are coming federally paid, so we've set those at a penny. They have to adjudicate it something in our systems, so we assign a penny to the cost. And I was ready to touch on our oral antiviral drugs that are open through our point of sale system, but because of the federal cost sharing agreement and the federal government covering a great portion of these drugs, they're priced at a penny, but of course assigned a dispensing fee. So the last element I wanted to address was Paxlovid and molnupiravir. So both of these drugs became available. And of course, Dr. Hoffman can address any specific questions around distribution. Sorry, I'm not going to get into that in this meeting. We can discuss that offline, and there's lots of other questions. But as far as Medicaid coverage of these oral antivirals, they are open on the point of sale system. They did come down on our drug file, I believe, early last week. We did set them as covered without any restrictions on our point of sale side. They are carved to fee for service. They are billed at the point of sale, reimbursed at 1 penny, but with a dispensing fee tied to them. So for the designated pharmacies who are getting Paxlovid and molnupiravir, they will be given a dispensing fee when these are processed at the point of sale. Okay, any questions on these? I'm sorry I didn't give you those first off, but I did feel that it was important to address these specific COVID-related things. And then I do want to address Aduhelm quickly.
Great. No, thank you. So we've had our P&T update, and Jennifer's given us great updates on where things are going with COVID. With that, I think we have a lupus nephritis review, so we'll turn the time over to the University of Utah.
I'm sorry, Dr. Kanan, could I back up real quick and just give one quick blurb on Aduhelm?
You're about 3 over.
Man, I am. You're right. So Aduhelm, just because it hit the news and it's been a topic of discussion this week, we presented Aduhelm prior authorization criteria to the DUR board, now a couple months ago, I think, maybe longer. And this was uniformly, this criteria was uniformly developed by our Medicaid fee-for-service and ACO partners. And, Medicare has published their coverage criteria. It is still draft. Of course, it's up for public comment, but that did hit the press this week. So many of you saw that, and the reaction was, wow, if Medicare is restricting access, what does that do to our dual eligible population? And what is the impact on that to the Medicaid side of business, knowing that if Medicare is not covering it as openly, but Medicaid is required to cover it underneath the Medicaid drug rebate program requirements of the Social Security Act, what does that look like? And the covered outpatient drug rule. So we're aware of this conversation that's happening. We know that we have until about April when Medicare's coverage criteria will become final. And at that point, we will be readdressing this, but we'll be evaluating it along the way. So just wanted to let you know that's on our radar. We're looking at it. We understand this is a huge cost impact potentially to Medicaid. And we're going to be looking at our coverage criteria and keeping an eye on what's happening on the Medicare side. So anyway, that's it. Anyway, more to come on that in the future. Thanks, everyone. Thanks for the extra time today.
You bet. When you said that's it, that's it. So, all right. Now to the University of Utah to talk about nephritis lupus.
All right. Let me pull my slides up for you here. Let me know when you can see those. Are those showing for you?
Yes, we can see them.
Oh, okay, great. Okay. So today we are reviewing 2 agents that have a specific indication for lupus nephritis, which is a manifestation of systemic lupus erythematosus, abbreviated SLE. I'll first provide some background information regarding SLE and lupus nephritis. SLE is an autoimmune disorder that causes inflammation and damage that can involve a variety of organ sites, including the kidneys. Disease presentation varies between individuals and is more prevalent among certain populations. Activity can be localized to a certain organ system or widespread to many. More women than men suffer from SLE, and patients are usually diagnosed between 15 and 45 years of age. Most cases experience a relapsing remitting disease course. There are about 200,000 patients in the US diagnosed with SLE, and about 40% of these cases also have lupus nephritis, which I'll refer to as LN. Pediatric onset SLE is usually more active versus adult onset, progressing to LN and other comorbidities quickly. About 20% of SLE cases are in children. LN manifests as kidney inflammation, proteinuria, hematuria, and compromised kidney function that can ultimately progress to kidney failure. LN is associated with increased morbidity and mortality. Due to nonspecific symptoms that can present in lupus, patients may experience a delay in SLE diagnosis, and many are found to have already progressed to lupus nephritis upon diagnosis. This slide highlights the many comorbidities that patients with SLE with or without LN can have, either due to the disease activity and chronicity or due to the medications that are used to manage disease flare. As you can see from the long list of potentially affected organ systems, which is actually not exhaustive, but just some examples, patients with SLE can be very complex, and LN may be only one of several manifestations a patient experiences. So the 2 agents we have approved in the US for lupus nephritis are belimumab and voclosporin. Belimumab also has approval for the treatment of SLE in general, both in pediatric and adult patients. Belimumab is an antibody that blocks the binding of B lymphocyte stimulator to its receptor on B cells. Antagonizing BLyS reduces B cell survival in total circulating B cells. Belimumab is administered parenterally on a weekly or monthly basis, depending on the route of administration. The subcutaneous form is for adults, and the intravenous form is labeled for pediatric and adult patients. Voclosporin is an oral calcineurin inhibitor taken twice daily. It interrupts pathways that normally lead to proliferation of lymphocytes, T cell cytokine production, and release of interleukin-2. Compared to older calcineurin inhibitors such as tacrolimus that have been used off-label among standard therapy for lupus, voclosporin appears to have a more favorable effect on lipids and glucose and does not require therapeutic drug monitoring, as does tacrolimus. The treatment approach for LN is addressed according to the histologic classification of LN. In the 2021 KDIGO guideline for LN, the place in therapy for belimumab and voclosporin is for initial treatment of active class 3 or 4 LN with or without class 5 as add-on treatment to standard immunosuppressants. These are listed among other initial regimen options. Among them are mycophenolate or low-dose IV cyclophosphamide-based regimens, which are strongly recommended. A tacrolimus-based regimen can be considered if patients can't tolerate standard dose mycophenolate or are unfit for cyclophosphamide. Other second-line options can be used if patients have an intolerance or contraindication to these recommended approaches or for refractory disease. Other scenarios mentioned in guidelines where aggressive immunosuppressive therapy may be required to control renal disease flare include class 1 or 2 LN with relapsing nephrotic syndrome and pure class 5 LN when there is worsening proteinuria associated complications of proteinuria, or nephrotic syndrome present. We must also consider that SLE disease flare can occur at extrarenal sites and can threaten other organ systems. So since belimumab has been studied and approved for SLE, it can be used for patients with or without LN to control extrarenal symptoms, reduce extrarenal relapse, and to facilitate steroid dose reductions. So let's look at some of the key characteristics of the phase 3 trials that led to approval of these products for lupus nephritis. There is one published RCT for each agent that established efficacy for active severe lupus nephritis. The BLISS-LN trial with belimumab was a 2-year study, and Aurora 1 with voclosporin was a 1-year study. Each included patients who met the 1997 ACR classification criteria for SLE, and each required biopsy-proven active LN of class 3, 4, or 5. There were different baseline requirements for the level of urinary protein to creatinine ratio. Another difference is that the belimumab study required patients to be autoantibody positive at screening. So belimumab was studied in combination with either an oral mycophenolate-based regimen or IV cyclophosphamide-based regimen. Voclosporin was studied in combination with a mycophenolate-based regimen only. The comparator arms were those standard immunosuppressants plus placebo in place of belimumab or voclosporin. Both treatments, belimumab and voclosporin, met their study's primary endpoint for renal response, outperforming standard therapy alone. For the belimumab arm, the effect difference in the primary efficacy renal response could be seen by week 24 and was maintained through the end of the study after 2 years of treatment. Results for key secondary endpoints such as complete renal response or reduced risk of a renal event or death also favored the belimumab arm over standard therapy alone. Compared to standard therapy alone, add-on voclosporin resulted in a higher proportion of patients achieving a complete renal response at week 24, and the difference was maintained to the end of the study at 1 year. Other secondary endpoints, such as partial renal response, were also in favor of voclosporin. As for the FDA-approved indications and wording, both agents are approved for adults with active lupus nephritis. The FDA did not place requirements regarding a certain histologic classification of LN. As previously mentioned, belimumab is also indicated for SLE, but for this particular indication, the FDA did specify that patients should be autoantibody positive. Belimumab is the only medication on the market approved for pediatric SLE. Like other strong immunosuppressants, these agents can increase the risk of serious infections and may increase the risk of malignancy. Unique warnings with belimumab include the possibility for hypersensitivity reaction, numerically higher rates of depression and suicidality versus placebo, and rare cases of progressive multifocal leukoencephalopathy. When using voclosporin, the prescriber should be aware of the possible drug interactions involving CYP3A4 and P-glycoprotein, and also consider QTc prolongation risk factors. Like other calcineurin inhibitors such as tacrolimus, voclosporin has similar warnings regarding the potential for neurotoxicity, nephrotoxicity, hyperkalemia, hypertension, and red cell aplasia. As for the utilization in the Medicaid fee-for-service population, over a 1-year period from December 2020 through 2021, there were less than 5 patients total receiving belimumab or voclosporin. All utilization was in adult patients, and all had ICD-10 diagnosis coding indicating SLE. Half of the belimumab utilizers and all of the voclosporin utilizers had diagnosis coding for glomerular disease in SLE. With this information, utilization appears in line with the indicated disease states of these products. So a simple approach for prior authorization criteria was proposed for these agents, mostly soliciting the provider's attestation that the patient meets the labeled indications. Page 31 of the report reviews PA considerations while keeping in mind the FDA indication wording and information from guidelines regarding these therapies. The prior authorization may include dose and age restrictions to be within the FDA labeling. You may have the provider attest that the patient has active lupus nephritis for voclosporin. For belimumab, the provider can attest that the patient has active lupus nephritis or autoantibody positive SLE. Educational notes regarding concomitant therapies that are recommended against in the labeling may be incorporated. In addition to avoiding drug interactions mentioned previously, voclosporin is not recommended in combination with cyclophosphamide. Labeling recommends against the use of belimumab in combination with biologics. However, the intention is probably regarding immunosuppressive biologics rather than non-immunosuppressive biologics such as insulin. So I'll go ahead and leave it at that. Thank you for your time. I might chime in again once you bring up the PA criteria. Let's see if I can. I'm all finished, Dr. Cannon.
Oh, okay. I thought you were bringing up the PA criteria.
Oh, so. No, I think Noon is going to bring that up in a little bit.
Yes. Before that, we have a drug rep from LUPKYNIS. You have a public comment.
All right. Let's move to public comment then. So we have Dwight, and Dwight, I'm not going to try and say your first name. I'll probably get it wrong. So.
No, thank you, Dr. Cannon. It's going to be Matt Baker is going to be presenting on our behalf.
Yeah.
All right. Thank you.
Yep.
Thanks, guys. Hi, Matt Baker, medical science liaison for Aurinia, who has the marketed product LUPKYNIS or voclosporin. And great job, Valerie, on the presentation of that data before. So I'm not going to try to duplicate some of the things you talked about. Looking at LUPKYNIS and the results from two pivotal studies, the phase 2 and phase 3, voclosporin or LUPKYNIS has demonstrated a really robust and rapid reduction of proteinuria in patients, adult patients with lupus nephritis. And this is the main goal of therapy with LN. And it's very important to thought leaders, since nephron loss is permanent, that proteinuria reduction is rapid in onset. And so the EULAR EDTA guidelines recommended a 50% reduction in UPCR levels by month 6 as a target goal for practitioners to achieve. In our clinical trial, we achieved 50% reduction in half of the patients treated with LUPKYNIS by day 29, so 1 month, showing the evidence of very rapid proteinuria reduction. And if I'll say that if there's an unmet need within this unmet need, it's better outcomes with non-white patients. And so we did a post-hoc study of our phase 3 and looked at self-identified Black patients, Hispanics, Asians, and whites. And we saw that self-identified Black patients were greater than 4 times more likely to achieve complete renal response by week 52 versus the placebo standard of care alone. Hispanic patients were greater than 3 times more likely to achieve this in the LUPKYNIS treated arm versus the placebo or CellCept alone arm. So really, when you look at the odds ratio plot, regardless of biopsy class, race, ethnicity, BMI, and age, there's a more favorable trend to LUPKYNIS treated patients versus the standard of care, CellCept. It is the only oral approved, FDA-approved therapy for the treatment of lupus nephritis, and therefore how it was structured in the clinical trial with background CellCept. It's an all-oral regimen for patients, adult patients with lupus nephritis. The other advantage of our trial design in LUPKYNIS is the ability to taper off steroids. So we initiated a very rigorous glucocorticoid taper where we targeted 2.5 milligrams of prednisone or less by week 12 in our study design. And that was achieved by the majority of patients. In fact, 9% of patients in our trial at week 52 completely tapered off of prednisone.
Matt, we've run out of time. Thank you, though.
Okay.
Thank you.
Thanks a lot.
All right. Quickly, does anyone on the board have any questions for Matt? All right. Seeing none. Thank you, Matt. We appreciate the information and your time. So, Noon, do we have any others, or we're moving to the PA criteria? Great. Thank you.
Yes. So we're going to present the criteria for Benlysta and LUPKYNIS. Before we start, we would like to receive the input from the board regarding a very low utilization at the you have been present. We have less than 5 patients on both Benlysta and LUPKYNIS. Both the medication right now is open and with no restriction. So if we decide to put the PA on this, we will be notifying the provider and the patient to submit, who are currently on these medications, to start submitting the PA. So we would like to receive the board input if it's beneficial for us to have the PA on these 2 medications. To begin the Benlysta, the criteria is the medication to be prescribed by or in consultation with rheumatologist or nephrologist. The indication is split into 5 years of age or older who has active autobody positive systemic lupus erythematosus or receiving the standard therapy such as corticosteroid, anti-malarial, NSAID immunosuppressive, or the patient who are 18 years of age and older who are active with lupus nephritis and also receiving standard therapy. The Benlysta is used as an add-on to standard therapy and not a standalone therapy. The initial authorization is up to 6 months. The reauth is up to 1 year. We put it in the note to make sure that the provider not use in concomitant with immunosuppressive biologic therapy, has not been studied and is not recommended. And a note that intravenous infusion is indicated for patients 5 years and older, while the sub-Q injection is indicated for 18 years of age and older. And that is for the Benlysta. Any comment, question on this PA?
Valerie, you had your hand up. Do you have a comment or question?
Yeah, well, I have a couple here. With respect to the specialist, a rheumatologist or nephrologist would be appropriate for an LN patient, but say the patient doesn't have LN as their primary manifestation, say their primary manifestation is hematologic, would you accept that type of specialist? Or if their primary manifestation is dermatologic? So I just kind of wanted to point that out there. And then my other question is the second bullet under the 18 years of age or older in the LN area. If that second bullet is requiring patients to be pre-treated before starting that therapy, recall that these therapies are for initial treatment. So I'm just wondering, is it are you just trying to get them to start the piece of their regimen that has the standard therapy? Like, as long as they're started on that, then they would qualify to receive the belimumab piece of the regimen?
You know, and Noon, maybe before you answer that, I may be able to speed this along a little bit. Can I just ask the board, given that we have
do we even need PA criteria given how little utilization there is?
that was my question, and so I'm really throwing that out to the board. I don't want to be the one to say, yeah, we don't need this, but I mean,
it seems like a lot of work for a lot of people for, you know, almost.
Yeah, and if I could comment, I mean, that was our sentiment as well. We are reviewing specialty drugs and unique classes and wanted to bring, these two agents to the board for evaluation. But we as a pharmacy team did have similar sentiments. So we appreciate the dialogue on this and your recommendations.
Okay, so let's do this. Are there any motions about having a PA or not having a PA?
Motion to elect to not have a PA.
Second.
All right, we have a motion on the table to not have a PA. Sharon did a very good job pointing out that it was an excellent presentation, so thank you for that. All in favor to not have a PA? Aye.
Aye.
All right, any opposed? Perfect. There we go, Noon. We saved you from having to review another form with us.
Thank you. So that is a motion to not having a BA and Benlysta. We probably will need another one for the LUPKYNIS for the record. Let me present the LUPKYNIS.
Can we get another motion?
So moved.
All right. Do we have a second? Have a second. All in favor? Aye.
Aye.
Aye. Aye.
All right. Great. Any opposed? Seeing none, we will move on. And maybe before we move to PCSK9 inhibitors, we better check and see if Jennifer has any additional updates. Doesn't appear to be so.
I'm out of updates for the moment. Thank you for the opportunity.
All right. Well, we'll turn the PCSK9 inhibitor prior authorization over to the pharmacy team. So thank you.
Thanks. It's coming. So the PCSK9 inhibitor, the main update to this form is highlighted. We are expanded the requirement to have medication prescribed by or in consultation. Before, it was only limited to an APCL or equivalent certified liver specialist, but we are expanding this medication to be prescribing by or in consultation with cardiologists or endocrinologists. Every other criteria stayed the same with what was presented to the board before. That is requiring the trial and failure of statin in conjugation with Zetia at the maximum FDA approved dose, or the patient is intolerant or allergic to Zetia, or any guideline recommended for patient who's meet the cholesterol level before the treatment with LDL more than 70 or non-HDL more than 100 for secondary prevention of cardiovascular event in patient with heterozygous or type 2 diabetes or two major risk factor defined by the current guideline, for patients who have LDL more than 100 or non-HDL more than 130 as a primary prevention, for patients who have LDL more than 160 or non-HDL more than 190, for patients with at least one risk factor, PCSK9 must be used in conjunction with statin or Zetia. But again, the main difference is we expanded the prescribed by or in consultation with cardiologists and endocrinologists. We also would like the input from the board to well define about the consultation with a specialist if the board can help us clarify that definition. We also have two public comment regarding the PCSK9.
Great. Thank you, Nun. I thought we did. And I will just ask you to maybe call on these people since I don't have their names or companies on my agenda.
Yes. The first one we have is Matt Ito from Reneron.
Yeah, thank you. This is Matt Ito, Associate Director in Medical Affairs at Regeneron. I'm also a past president of the National Lipid Association. And thank you so much. We're really fine with the prior authorization. I just wanted to make a few comments on FH to remind the committee and those involved in the evaluation of the prior authorizations that, FH really is a deadly genetic disease of lipid metabolizing, and it affects about 1 in 250,000 individuals. And these patients really have a high risk of CAD, 20-fold increased risk of CAD because of their high LDLs from birth. So really effective treatment is required. And as you point out in your prior authorization, high intensity statins plus non-statins, including ezetimibe and PCSK9 inhibitors, really are required to achieve acceptable levels in these patients. So again, early and aggressive LDL lowering is essential to reduce CV morbidity and mortality in these individuals. And unfortunately, many of these patients are underdiagnosed and then undertreated. So I'd just like the committee to keep that in mind as we move forward with these novel non-statin agents. So I thank you all, and I'm available for questions if that you may have on alirocumab.
You bet. Thank you, Matthew. Do we have any other questions from the board for Dr. Ito? Seeing none. Noon, do we have another public comment?
Yes, we have one more, Dr. Philip Westat from Novartis. Dr. Westat, if you are speaking, I think your mic is mute.
If you're calling in, you need to hit *6.
I can see that he is attending right now. Not sure if he experienced some technical issues.
Noon, why don't we move on in reviewing the criteria, and if Phil gets his IT, whatever issues may be happening resolved, then I think he can raise his hand or put something in the chat to let us know he's available, and we can actually check at the end of this, maybe before we make a vote.
Yes, please. Do you have any questions regarding the prior authorization or the extended criteria?
And I think the one issue I have, or I don't have any issues, but the one question I have, which is not an issue, is what kind of utilization have you seen? And without understanding how much utilization you have or how appropriate that utilization is, it's hard to say what changes, if any, we need to the criteria.
That is a good question. Brian, do you know that answer by chance?
Could you repeat the question?
So in terms of the utilization around PCSK9 inhibitors, how much utilization do you have, or does Medicaid have, and is it appropriate? Is there a
I
belief that there are issues?
I believe it's very low. If you give me just a minute, I can double check that. Maybe it's too low. And that's kind of my recollection is I think we have extremely low or no utilization. Yeah, I'm saying no utilization.
Yeah, and Brian, we have a real, speaking on the plan I represent, we have very low PCSK9 utilization right now.
Mm-hmm.
And I don't know that we view it as an issue with the criteria we have in place, but I guess comments from the committee in terms of the criteria for PCSK9 inhibitors. I mean, I think Noon had mentioned the in consultation with a specialist, and we have certified lipid specialist, cardiology, or endocrinology. I don't know that that would be a limiting factor here, especially on the FH patients.
I think the issue could be, and Noon, correct me if I'm wrong, but really we're thinking that it doesn't have to be specifically a lipid specialist. There's so few in the state, and again, a cardiologist or endocrinologist could be an appropriate prescriber for these.
Okay, no, that makes sense. I think that's a good recommendation. Sharon, you had your hand up.
Yes, thank you. I'm not in those circles much, but would this come into a kind of stroke prevention group? Because those are generally neurology. So I don't know if that's a different specialist to be named. Any other thoughts about other specialists? I wouldn't be, wanting to limit.
Or
I
it
mean,
would
it would be an odd one off, but possibly. Thanks.
Noon, did you start to say something, or was that someone else?
I was trying to say, would the board, even if we want to expand in this, we do sometimes, there was a PA coming from a cardiologist, mid-practice. And also, since this medication is having proving that is causing the reduction in cardiac vascular event, would it be even maybe like a family practice, or should we eliminate that criteria in general and keep other criteria on?
Yeah, I mean, my personal opinion is at a point in time, your lipids are of a level that you might need a PCSK9 inhibitor. I don't know that we want the patients with just standard family practice. They're at a level probably where they need other additional consultations or recommendations. So I don't know how the group feels about that. Maybe I can interrupt this conversation right now. Phil Wedstad is available now to comment for Novartis. And so, Phil, why don't we turn 3 minutes over to you for any comments you might have?
Yeah, good morning. Can you hear me okay?
Yes, we can. Thank you.
Okay. I apologize. Technology is not my friend this morning. Thank you for the time. My name is Phil Wedstad. I'm a medical science liaison with Novartis Pharmaceuticals. I wanted to share some new information with the committee this morning regarding Leqvio or inclisiran. This is a medical benefit drug. So I wanted to start off with that just in regards to when you're developing prior authorization criteria for Leqvio. Keep in mind in regards to a medical benefit administered medication. So Leqvio or inclisiran was approved by the FDA on December 22nd of last year. as the first-in-class small interfering RNA, or siRNA, cholesterol-lowering agent indicated as an adjunct to diet and maximally tolerated statin therapy for the treatment of adults with clinical ASCVD or heterozygous familial hypercholesterolemia who require additional lowering of LDL cholesterol. Leqvio is a double-stranded siRNA that directly targets the liver for specific uptake by hepatocytes. In the hepatocytes, Leqvio utilizes RNA interference mechanism and directs catalytic breakdown of the PCSK9, of the messenger RNA for PCSK9 protein. This increases LDL cholesterol receptor recycling and expression on the hepatocyte cell surface, which increases LDL cholesterol uptake and lowers LDL cholesterol levels in the blood. The recommended dose of Leqvio in combination with maximally tolerated statin therapy is 284 milligram, administered as a single sub-Q injection initially, again at 3 months, and then every 6 months. Leqvio should be administered by a healthcare professional. The safety and efficacy of Leqvio was investigated in 3 randomized, double-blind, placebo-controlled 18-month phase 3 trials, Orion 9, 10, and 11, that enrolled more than 3,400 adults with HeFH or clinical ASCVD who were taking maximally tolerated statin therapy and who required additional LDL cholesterol lowering. In each study, patients were randomized 1-to-1 to receive sub-Q injections of either Leqvio, 284 milligrams, or placebo on days 1, 90, 270, and day 450. The primary endpoint was the percentage change in LDL cholesterol from baseline to day 510. In Orion 10, Leqvio achieved a 52% LDL cholesterol reduction, and in Orion 11, Leqvio achieved a 51% LDL-C reduction.
Thank you. We're out of time. But we appreciate your insights. Thank you.
Thank you for the time.
I am trying to talk with my microphone off, so I apologize. Only 3 years into this thing, and I can't get it right. Anyone have any questions for Phil? Okay, seeing none, we're in the process of discussing the specialist designation there. So and I guess my feeling is it doesn't have to be a lipid specialist. I mean, I think, do we want to go, I think Sharon had mentioned neurology. Do we want to go beyond a cardiologist, endocrinologist on this? And if someone in neurology was the consultation, I assume the state has a process for exceptions.
Yes, there only a PA that we can review based on our clinical criteria, and then of course considerations.
Okay.
It's really my ignorance, sorry, as to whether or not this this kind of medical management is overlapping over into the stroke prevention world. Maybe people on the call are more familiar. I just don't know how much crossover there is into that clinical area at this point in time.
Stat, I believe you want to maybe address that.
So from what I can find, it's really about preventing cardiovascular events and not thromboembolic events, at least as far as the information we can find right now.
When I would be okay if we changed this to just say in consultation with a cardiologist or endocrinologist.
And you would like to cross the APCL certified lipid specialist? Or you would like to keep that, would the board like to keep the certified?
Well, I guess what I'm saying is the cardiologist or endocrinologist would not have to be a certified lipid specialist.
Correct.
Right.
So I think we can take that off and just say cardiologist or endocrinologist.
So remove the ABCL or equivalent certified lipid specialist language, just for clarity.
Yes.
Thank you, Eric.
If that's a motion, I second it.
I'm sorry. I missed somebody's comment there, I think.
Oh, that was me. I just said if that's a motion, then I second it.
I don't know that it was a motion, but I think we have agreement on that. Trial of statins. I would think that's a given. I'm okay leaving it just because I don't know that it is a barrier to the drug. I'm not sure. And it may be, are we looking at intolerant or allergic to Zetia? We aren't asking about intolerance. Well, okay.
The rest of the PA has been approved by the board as a previous meeting. The only change this time was the provider type.
All right. Well, I will leave it to the group if we need to review more or if we're comfortable with the one change in the specialist, and I'll leave it to you to make a motion.
It would be helpful to get the board's input on, this is Joe at the state, to get the board's input on the phrase consult for us folks who have to implement these. As we did with Spravato, the board was kind enough to give us some additional words around that. So is it a quick phone call, or is it a full blown, physical exam and physical visit? What does consult look like? I'm sorry, Lynn, for jumping in. I apologize.
Thank you, Joe. I don't know that any of us really have an idea, because I think that could happen, as you just said. It's in consultation. Consultation can happen in an email, a phone call. It can be a second review in that the patient goes in for a visit. My personal opinion, given where your utilization is, that it's an attestation, and we leave that definition of consultation to the individual submitting a form. They're attesting that it's happened. And so, at the point in time, everybody just checks that box and there's a problem, then I think we can come back and review it. But current utilization would suggest no problems. Or maybe that was the hurdle. Hearing lots of crickets right now. So hearing no comments or anything else, I will make the motion then that we accept the language recommendation to eliminate the ABCL or the certified lipid specialist language as highlighted on the screen. Is there a second?
My second still stands.
Second.
Catherine's second still stands. Kumar was fighting to get in there. All right. All in favor?
Aye.
Aye.
Any opposed? All right. With that, unless someone at the state wants to correct me, I think we have completed our tasks for today. So thank you, everyone, for your contributions. Thank you for the public comment we've had this morning. Our next meeting is February 10th, same time, same place. So we will be talking about codeine use in children. So we plan to have another exciting meeting. So anyway, Thanks, everyone. If I could get a motion to adjourn. Kumar?
So, second.
Great. Motioned and seconded, and we are gone. Thank you, guys. Appreciate everybody.
Thank you.
Thanks, everybody.
Nice day.